My last talk is the optimal repair of recurrent inguinal hernia. I have no conflicts of interest. And what is the best way to fix a recurrent inguinal hernia? And my answer is, it depends. It depends what the first person did and who the patient is. Again, over 2,500 TEPs, over 1,400 open repairs. My bias, I'll tell you right up front, select the patients carefully, prepare them for the operation. They need to understand that this is the second time or the third time or the 9th time, as the case may be, that it's going to be harder to fix it correctly. So we need to do our best job now. The easy access is what I'm looking for. So if the first person started from the anterior, I want to go posterior. I want a virginal plane. If they started posterior, then I want to go anterior. And ultimately, I like a tension-free mesh repair. So I'd like to ask the audience, if I could, how do you fix an inguinal hernia right now? What's your go-to? A standard person comes in, patient symptomatic, has an inguinal hernia. What will you choose as your repair? 49% Liechtenstein, 10% mesh plug, 2% hernia system, 26% TAP or TEP. Nobody's doing Bassini, Schuldeis, or McVeigh, and robotic 13%. So that's really helpful for me because I'm going to base what you did, if I'm going to fix your hernia, or if I fixed open, you're going to fix my hernia. And I think this is important that we understand what each other does. Dr. Nyhus, some 50 years ago, came up with a classification for different types of hernia. I'd like to use it a little bit on how to fix a recurrent hernia. And he had classes 1, 2, 3, and 4. And let me go over these classes if I could. So a type 1 hernia is a pediatric hernia. There's nothing wrong other than the hernia sac is up in through the internal ring. Most pediatric surgeons and general surgeons fix those with high ligation. Type 2 is a larger defect through the internal ring, indirect hernia sac, or potentially direct. Again, femoral vessels, epigastric vessels. Type 1, pediatric hernia. Type 2, bigger defect at the ring with a large sac coming through. Type 3A will be a direct defect through Hesselbach's triangle. Type 3B is a pantaloon that the whole area has been blown out. Type 3C is a femoral. And type 4 is a recurrent hernia. Looking from the posterior aspect, from the inside of the abdomen, knowing where the bladder is, the pubis, and the rectus muscle. A type 1, again, pediatric, small little defect, the sac's going through the internal ring.